If at any point anyone has questions, feel free to pop them in the chat or unmute yourself, raise your hand. If I'm going too fast, too slow, please just let me know. Okay, awesome. I'm going to see if anyone else needs to be admitted. All right. Another disclaimer, this is a broad overview. It's not a replacement for studying. Use this tool to guide your studying efforts. So kind of as you're studying, feel free to kind of take these PDF slides I've given you all and kind of mark on them, write on them, all of it. I posted in an announcement for you guys the link, the PDF copy, everything you'll need is an announcement on Canvas. So let's go ahead and begin our intro to pharmacology. So first we're going to talk about how drugs work. When we're referring to pharmacokinetics, how do those drugs move throughout the body? When you think kinesiology, that's kind of the study of movement, movement of the body. So just think that kinetics, that's movement. So we have 4 different phases of drug movement throughout the body. That's going to be your absorption, your distribution, metabolism, and excretion. So one thing I do want to note is that when we take our drugs, regardless of whatever type, whether it be oral, IV, IM, they're all going to get absorbed into the bloodstream. From then, the bloodstream with the drugs travels throughout the body. That's our distribution. And most of our drugs are metabolized in the liver. Keep in mind, metabolism is different than excretion. And a lot of our drugs do require a loading dose so that they're not completely metabolized. Pharmacodynamics, this is more what the drug is doing to the body. So a couple different topics we'll talk about today is receptors. Remember, agonists turn on, antagonists turn off a property. Specifically with antagonists, they turn off by competing for a receptor site. So if my receptor needs to attach to A in order to unlock it and do whatever job it has to do, if I have an antagonist, it's going to compete with whatever's trying to bind to that. So instead of, whether it be a protein, etc., instead of binding, essentially what's happening is it's kind of like false, fake, if you will. Antagonists will bind to that receptor site, but it's not going to produce any sort of response because it's kind of like a false. It's a key that kind of fits in the lock, but it's not going to turn on the lock. It kind of just fits in there. Like if you have multiple keys, you accidentally jam one in the door. Well, yeah, it fits in the door lock, but that's what an antagonist does. When we're talking about post-receptor effects, this is what happens after that receptor's been turned on. Those are our side effects or our adverse effects. Side effects, normal expected findings, your headache, dizziness, nausea, etc. Adverse effects are something that we really need to pay attention to because that's not normal. Whereas our side effects are pretty normal expected findings in the kind of way that maximum benefit, minimal harm. So that's just kind of something to keep in mind. Like our adverse effects would be our steatosis, anaphylaxis, angioedema, etc. And then what type of chemical reaction is happening? Additive or about those. So how do we rate medications? Are they good? Are they bad? What are we doing? So medications, they have to be effective. It has to do what we want it to do. Our anti-tubercular meds, we really want them to help cure our patient from tuberculosis, get that out of their system. That's what it's supposed to do. We also need our medications to be selective. That means it's eliciting the intended response with minimal side effects. So it's doing what it needs to do, but it's not producing severe side effects, such as damaging the body, etc. Maximum benefit, minimum harm, we've talked about. Additionally, drugs have to be predictable. That when I take my ibuprofen, I know that within a few hours, my pain's going to go away. I know what that drug's going to do. I can predict the peak, the onset, duration, etc. If a drug says it peaks at 1, it peaks after 1 hour, it better peak after 1 hour. Okay. They also have to be cost friendly. And we'll talk about that with our generic versus brand names as well. User friendly means easy for our patients to do themselves. Um, a lot of patients in the hospital get put on warfarin drips so that way they can kind of wait for some other meds to kick in. But do we think that it's easier for a patient to swallow a Coumadin pill or to administer it subcutaneously? That's probably a little difficult for the patient. So we're going to make sure that we assess our patient's kind of function and what they can do. I guarantee you, oral pills are going to be the best for a majority of the patients. And we really want it to follow protocol and really be approved by the FDA. And we'll talk about what might not be approved by the FDA. So when we name our drugs, they're classified by what they do. Antihyperlipidemics, they lower cholesterol. When you're in the clinical setting, you might not be able to ask your patient, are you on an antihyperlipidemic? They might not know what that is, but you'll tell them, are you on your cholesterol pill? And they'll know what that is. But for the purposes of pharmacology class, we really and the end and the NCLEX, we really want to know what the classification of the drug is. For example, we might not know every single brand name of every antihyperlipidemic, but if we can determine that that drug is an antihyperlipidemic, a lot of them function the same, similar side effects, so it allows us to recognize patterns of drugs, and that's really what I encourage you guys to focus on. Don't get too caught up in the brand names. Know what is this drug classified as, and that helps a lot. So, the generic name, mostly it's going to be used. This is what is used by healthcare providers when we're speaking. Okay, if you call pharmacy, you're not going to be able to call pharmacy and say, "Hey, I need 5 milligrams of Advil." One, they might not even have the brand Advil, but they're not really going to know what that is. When you're communicating with a physician, a pharmacist, or anyone, you have to use the generic name. Okay. However, when you're talking with your patients, they most likely know what the brand name is. And a good rule of thumb, if you're having a hard time pronouncing the medication, that's probably the generic name. If you're getting like tongue tied, tongue twisted, whatever, it's probably the generic name. And it's also going to be lowercase. The brand name, this is what our patient knows. The first letter is always capitalized, and it's usually followed by like a symbol, like a trademark, the like R with the circle around it, etc. So on the left, we see cetrizine hydrochloride tablets, 10 milligrams, and we see Zyrtec. What is the generic name, and which one's the generic and which one is the brand name? What do you guys think? So our Zyrtec is the brand name. Notice how brand names are usually a bit more expensive than the generic name. This is also how we advocate for our patients. We want to really advocate that the medication they need that they're able to afford. So it's really important to kind of know those differences. The generic name for Advil is ibuprofen, but it might also be called Motrin. It might be a bunch of other different names, so just keep that in mind. When we're talking about over-the-counter meds, these medications do not require a provider order. These are more cost-effective for the patients because the prices are lower and they don't have to pay fees to go visit their doctor or to go to an urgent care. However, over-the-counter meds usually are more for symptom management, runny nose, sore throat, itchy eyes, rash, even pain. Pain is a symptom. So a lot of your over-the-counter meds, they don't require a provider order. However, if you're taking care of a patient in the clinical setting, you need to be asking them, what medications are you currently taking? And it's important that they don't just tell you all the medications that they're prescribed, but also what other over-the-counter meds have they taken. And that's a really important concept when we're doing medication reconciliation. There's lots of different drug interactions. You can have drug-drug interactions, meaning these two meds can't mix. And then there's also drug-food interactions, and those you kind of just know when you learn more in depth about some meds and the nursing considerations that do follow. Um, Lots of our CAM meds, our complementary and alternative medications, have various drug interactions. So always, if a patient has recently told you, hey, I just started taking kava kava, or I just started taking, this tea that's caffeine free, but it's like giving me energy, you really want to kind of ask them what they're taking so you can say, okay, is this safe to take with some of the other stuff they might also be taking? Or is it safe for this patient with this certain health condition? And keep in mind, these medications are not approved by the FDA, so they can pretty much put whatever they want on the shelves. So really make sure that you are doing a full med history on your patients. You want to know what meds are you being prescribed, what medications do you take over the counter, and is there any other complementary or alternative medications that you're taking? That's very, very, very important. We also want to ask them about vitamin and mineral intake. Keep in mind, too much of a good thing isn't always a good thing. Okay. So vitamin and mineral supplements are great for patients that need them, patients that are severely malnourished, whether they might be undergoing chemotherapy, etc. But if we take too much of a dose, specifically vitamins A, D, E, and K, this can become really toxic for these patients. So just keep that in mind as well. So let's talk about safe medication administration. So things to just keep in mind when you are preparing to give a patient any medication, and I encourage you all to be doing this in the clinical setting. You're usually assigned a patient. Look at your patient's med list. Always say why. Always ask yourself, why is this patient taking this medication? Oh, well, if my patient has a history of high cholesterol, it makes sense that they're on an anti-hyperlipidemic. But also think about it on the flip side. Well, I know my patient's diabetic, so they have insulin. However, their blood sugar check showed that their glucose was 60, but they're prescribed insulin. Is it appropriate for this patient? The answer is no. At that point in time, it's not appropriate to give insulin to that patient. So that's really what you guys need to be thinking about as well. Also, is this medication expired? It happens to the best of us. Sometimes you go to give a med and you notice it's expired. So just look at that. Also, what are the main side effects? Now, you don't have to go up to your patient. This is going to be nausea, vomiting, diarrhea, etc. But just know if it causes an upset tummy, maybe tell your patient, take it with some crackers. Also, when to call 911 or when to go to the hospital if you experience an adverse effect, and how do we kind of manage, mitigate, etc. We'll also briefly discuss pregnancy categories. Just know that the lower down in the alphabet, the more severe it is for pregnancy. So just keep that in mind. There are 6 rights of your medication administration. So always review that. NCLEX likes to test a lot. They'll give you kind of a paragraph and they'll say like what's missing. So that's something, especially for your dosage calc exams as well. They always like to, what's missing. So we always, when we're getting a prescription, we always have to go down the list. The right drug. Do we have the name of the drug? Is it for the right patient? Is it the right dose? We need to know what the dose is. Is it in the right route? Is it oral? Is it IV? Is it IV push? What time do we need to give it? And then you follow up with right documentation that it has been given. So when do we review the 6 rights of medication administration? Well, we always do it at the MAR when it shows up their list. You always have to, once you pull it from the MAR, because sometimes meds spill over from the other little bucket. So even though you might pull it from where the arrow is telling you to pull it, you still check. And then finally, when you're at bedside, you scan your patient's wristband, you identify name, date of birth, etc. You always have to ask name and date of birth whenever you give any sort of medication. Even if you're hanging saline, you always have to verify, okay? So just keep that in mind. But as you're kind of verifying their identity, you're also going to verify again that you have the right meds. And don't worry, there's so many safety protocols put in place in the hospital. If you follow those safety protocols right, such as scanning your patient's wristband and scanning the meds before you give them, um, you're going to be very, very safe in the clinical setting. I know it sounds tedious, but it's very, very important. So, what are some different routes of administration? Orally, we can have scored pills. This is really important to understand. If a pill is scored, this means it can be cut. So, let's say my patient needs 250 milligrams of metoprolol and they have a 500 milligram scored pill. Well, I can cut that pill and they can take half today and half tomorrow. No problem. But if I have a coated pill or a regular pill, I can't cut it. Okay, so we need to call pharmacy and say, hi, I either need a scored pill or I need 250 milligrams in this extended release tablet. Do not crush your extended release. If you have a patient with swallow difficulty, sometimes you crush up their meds and you put them in applesauce. You can't do that with coated pills. So you might have to, again, call pharmacy, advocate, my patient has dysphagia. Can you give us an oral medication? So just really keep that in mind. Lots of other different routes as well. Something that always confused me, what's the difference between enteral nutrition and parenteral nutrition? Well, enteral nutrition, that's just kind of think of it as a protein shake. It's just got nutrients, it's just got stuff usually going through like an NG tube down the nose or a G tube directly into the stomach. Total parental nutrition, that is going to be hung like saline, and it kind of looks like saline. It might be a little bit yellow or a different color, but it's got fluid, electrolytes, and nutrients, and it's tailored to the patient. It's specifically made for them by pharmacy. Safety considerations across the lifespan, just very, very broad. Pediatrics, they have a higher metabolic rate, so their medications might not last as long in the body. Whereas geriatrics, they have decreased metabolic rate and reduced excretion, so they're susceptible to toxic doses. And for geriatrics, that med is going to stay in the body a lot longer. Whereas for pediatrics, that med is going to be quickly excreted, quickly metabolized, quickly excreted. It's going to have an earlier peak, quicker onset, quicker duration. However, this does not mean we should be bumping up our pediatric patients' dose. That is not safe. Remember, their organs, everything is still developing. This just means we might need to give medications more frequently for this population. And with our geriatrics, keep the meds the same, but maybe we're giving it less frequently, maybe once or twice a day. With pediatrics, we might be giving them maybe 4 times a day. So that's kind of how you can kind of relate the two. So now we're going to get into our drug prototypes, okay? And when I mean prototype, this is the drug that we're going to use to kind of help us understand what adrenergic drug is. So I kind of did a little list for you guys, but we are going to be talking about our adrenergics. There's a couple different types of adrenergics, and we will discuss that. So, what are adrenergic drugs? They can be split into a few different categories. When we're talking about our beta drugs, these kind of affect a smooth muscle, like a muscle on a heart or a muscle on a lung. Okay, think of that. Not our alpha. Those are our alphas. Erase what I just said. When we're talking about betas, it's either your heart or it's your lung. Directly to the heart, directly to the lung. So when you have a beta 1 drug, these act on the heart. Beta 2 receptors are on the lungs. Think 2 lungs. And then they kind of increase blood pressure, decrease blood pressure, etc. When we're talking about our alphas, this is like our smooth muscle. And we've got kind of this smooth muscle really everywhere in the body, where our betas are a little bit more specific to like an organ. Because we've got blood vessels all over the body. We've got vasoconstriction, vasodilation all over the body, but our betas think it's kind of select to either the heart or the lungs. And the way I like to remember it, beta 1, you have one heart. Beta 2, you have two lungs. Okay? That's just something I like to use to kind of help it make sense. So when we're talking about our alpha 1, this stimulates vasoconstriction. So this is going to raise our blood pressure. So if we have an alpha 1 agonist, this is going to promote vasoconstriction. If we have an alpha 1 antagonist, this is going to compete with vasoconstriction. Vasoconstriction is now not going to occur. So that's kind of how we use agonist versus antagonist, and we'll talk about that, I promise. When we think alpha 2, think inhibits. So this inhibits vasodilation. Remember our rest and digest phase, when our blood pressure begins to drop and we kind of begin to calm down? That is our alpha 2 working. Again, agonists stimulate the SNS, sympathetic nervous system, fight or flight. Antagonists block the sympathetic nervous system, help promote rest and digest. So again, just to kind of repeat, alpha 1 receptors, this is going to increase our BP. Alpha 2 receptors, this is going to decrease our BP. Okay, also can decrease insulin, but for the purposes of this exam, I want you to kind of think more along the lines of decreasing our blood pressure. Beta 1 receptors, this is going to stimulate our RAS, our renin-angiotensin system, all of that. It's going to increase our blood pressure by acting on the heart. Our beta 2 receptors, this is going to help us kind of rest and digest, relax the smooth muscles of the lung, decrease that GI, uterine relaxation, all of it. So again, rest and digest, that's our beta 2, okay? And they have effect on the lungs. Specifically bronchodilation. So highlight star bronchodilation. If you have a beta 2 drug, pay special attention to the lungs. Again, antagonists block the receptor and its response. Agonists stimulate the normal response of the receptor. So, agonists, in summary, they stimulate the sympathetic nervous system. So again, our use depends on what receptors are activated. So again, I just kind of listed some of the more common functions, like our alpha 1 agonists, and all of that. So that's there for you guys. So let's talk about our adrenergic agonist, specifically epinephrine. What I want you to know about epinephrine, this is non-selective, so it's kind of acting on everything. It's a very, very good drug, usually used in our emergency situations. The reason that this drug is so great is because it increases our blood pressure, which is good when you're in shock and your BP is dropped. You want, your BP to rise. So because this is non-selective, it's acting on alpha 1 and specifically our beta 2 as well. So what's happening with epinephrine, it's increasing our blood pressure, but it's also promoting bronchodilation, which is acting on a different receptor. So that's why this is our drug of choice, especially for allergic reactions, because it's going to increase our blood pressure, get us out of shock, but also promote airflow, which is really good. And why does it do this? Because it's non-selective. So it's a really, really, really good drug to use. It's got a very quick onset and peak, but a lot of our signs and symptoms are more anxiety related. So that tachycardia, hypertension, restlessness, nausea, vomiting, just because we just gave them a pretty big jolt of epi that works very, very fast. So whenever you're administering epinephrine or you have a patient that's receiving epinephrine, we do need to get a quick set of vitals on them, check their heart rate, blood pressure, respiratory rate, etc. for our epinephrine. Antagonists, on the other hand, kind of just think block. So if you have an alpha antagonist, this is going to promote vasodilation, resulting in a decrease in BP. Our beta agonists, these cause a decrease in heart rate. With that decrease in heart rate, if my heart rate drops, my blood pressure also is going to drop. So just kind of think about that. So, our drug of choice for our alpha 1 adrenergic antagonist is going to be prazosin. Most of your alpha 1 adrenergic antagonists, I know it's a mouthful, but most of your alpha 1s end in that zosin, whether it's SYN or SIN. So, we give these drugs to treat hypertension. It's not a first line treatment. Usually, we use it with a couple other different things. But the main job of a Zosyn drug is to kind of get us out of that high hypertension or hypertensive crisis. How is it doing this? It's blocking that norepinephrine. And it's going to cause vasodilatation. Antagonists, vasodilation. Okay. Just again, be cautious with this drug because it's contraindicated with any sort of ED medication, such as nitroglycerin, which we'll talk about later, but this will help you when we get to our cardiac portion. However, something to keep in mind with a Zosyn drug is something called first dose hypotension. Usually, if we give this drug for the first time, it's going to drop their blood pressure like crazy because the body's not used to it. But once we kind of give it more frequently, it's going to drop it to a therapeutic level. Okay. Our alpha 2 antagonist, again, it's used for difficult to control hypertension. However, this one just acts on a different receptor. Same function, same everything, it just acts on a different receptor. So this is actually going to work on the arteries and the arterioles and the blood vessels to kind of help and really, really drop the blood pressure for these patients. Most of your side effects, dizziness, fatigue, dry mouth, any patient that's on an antihypertensive, medication is a fall risk, especially with that orthostatic hypotension. However, this drug is pretty hard on the kidneys, the liver. So it's really not recommended for patients with decreased liver function. And remember, the liver does most of the drug metabolism. Again, this drug has the 3Ds, the dry mouth, drowsiness, and dizziness. This drug, you can give it patches, orally, etc. But remember, you have to taper your dose. With this drug, you can't abruptly stop because you'll have rebound hypertension. So now we get to talk about probably one of the most common drugs used ever in the clinical setting and just used by patients on the day-to-day, and it's metoprolol or atenolol. These are our beta blockers. Specifically metoprolol, this is a selective beta blocker, meaning that it's only going to work on one thing. So just kind of keep that in mind. What do beta blockers do? I kind of like to remember it, the BB for beta blocker. They help control the beat of the heart. So this helps manage our heart rate. If you have a patient who has a consistently elevated heart rate, metoprolol is a very good drug to kind of drop the heart rate, manage blood pressure, manage dysrhythmias. We also do use this medication for patients with anxiety because of its just calming effect. This drug, again, it's a really, really good drug, pretty safe for the most part. But we always want to make sure we get a good set of vitals before giving these drugs because we don't want to give a patient metoprolol if their heart rate is 55. It's going to drop it even more. We don't want to give metoprolol if the patient's blood pressure is 90/60, and that's a really common theme. If you're giving a cardiac med, assess their cardiac status. Vitals are really good. Heart rate, are you dizzy, short of breath, etc. So really just kind of write that down because that's very, very important. However, one thing I want to talk about, if you have a non-selective beta blocker, this means it's going to work on both the heart and the lungs. So if your beta blocker is non-selective, such as propranolol or acebutol, this is not good for patients who are asthmatic or have COPD. Because of their respiratory issues, it's going to act on the lungs and it's not going to be good for these patients. So just kind of keep that in mind as well. If your patient has a history of asthma or COPD, instead of giving them propranolol or acebutolol, we want to give them metoprolol or atenolol. So just know that metoprolol and atenolol, they are selective beta blockers. So they're specifically working on the heart. So again, we always check our vitals before administering, monitor for bradycardia. What do? We have to check our blood pressure before, and you're also going to check their apical pulse. Again, these drugs also need to be tapered. So now we're going to talk about our cholinergic agonists and cholinergic antagonists. Remember, agonists turn on, antagonists turn off. So what is our cholinergic system? It's our parasympathetic nervous system. Everything we talked about prior was more based on that kind of sympathetic, and is it inhibiting the sympathetic nervous system or is it activating the sympathetic nervous system? Now we're talking about the parasympathetic nervous system. Again, more of our rest and digest phase. So there's multiple different types of receptors. You have our muscarinic, nicotinic, and cholinergic. We're going to spend most of our focus on our cholinergic drugs because they are stimulated by acetylcholine. And we talked a lot about in complex health what disease process involve acetylcholine. Well, our Parkinson's do, our Alzheimer's do, even our Huntington's. So acetylcholine is a very, very important neurotransmitter. So just really do keep that in mind. Our cholinergic agonists stimulate the parasympathetic nervous system. They help induce rest and digest. Cholinergic antagonists, they stop the actions of acetylcholine and thus prevent the parasympathetic nervous system from being activated. So our first one is going to be our chloride drug. This is a cholinergic antagonist, also called a parasympathomimetic. I just remember cholinergic agonist. So this helps our patients with urinary retention. This is a drug of choice for that. Remember, our fight or flight kind of promotes urinary retention because we're kind of trying to save everything. But when we're in our rest and digest phase, that's when everything relaxes. And what also relaxes our bladder and helps kind of get rid of that urinary retention that was caused by the activation of our sympathetic nervous system. Okay, really acts on our bladder muscle. However, a major side effect of this can be bradycardia. So again, remember, take their blood pressure and their heart rate before administering. These patients, we also want to be monitoring their INO, intake and output, just so we can assess kind of the status of that urinary retention. Atropine is something I want to talk about. Atropine will help what's the word I'm looking for? Atropine is used if someone has a cholinergic agonist overdose. Okay, so if someone's overdose, we can give these drugs atropine. So if I give my patient bethanyl chloride and I reassess them and now their heart rate is 40, I'm going to give them atropine. Okay, it's going to kind of compete with this receptor site, and it's going to help reduce the effects and help my patients' heart rate get back up. And here's some more on atropine. Atropine can also be used for other cases of severe bradycardia that might not be directly caused from another drug. We also use atropine a lot pre-op, just because this helps with secretions, especially if they're going to be intubated. We want to help kind of reduce a lot of those secretions. When we're talking about atropine, this is an anticholinergic. So all side effects of our anticholinergics are our dries. They will dry you up. So you're going to have decreased secretions, decreased urinary output, constipation, blurry vision, etc. And why? This is because this drug is halting our rest and digest, thus increasing heart rate and cardiac output. So again, before giving this drug, we always monitor their heart rate and rhythm. And this drug can actually be reversed with pheostigmine. So if you've given too much atropine, there's a reversal agent for that. So now we're going to talk about some more of our brain medicines, our stimulants, and our stimulants, depressants, and our anti-seizure medications. I did want to put a little asterisk. There's lots of different drugs we can give for epilepsy. Just know that we have to frequently monitor their blood levels, and that most anti-epileptics do cause bone marrow suppression. Just a little asterisk. So our stimulants, what do? They stimulate the CNS. This can be our amphetamines, our analeptics, anorexins, etc. Lots of different causes. They can be used for kind of more cognitive and behavioral issues such as ADHD or narcolepsy, which we talked a lot about in Complex Health 1, and help reverse respiratory distress. One thing about stimulants, they have a very high abuse potential, so they're usually kind of used cautiously. Amphetamines, these are your like methamphetamines. They will increase alertness, but they're going to make you very, very restless, and they do a good amount of work on the heart. So they might have some cardiac symptoms of palpitations, maybe an irregular rhythm, etc. Anorexins are usually used for weight loss. And then analeptics, they actually stimulate respiration. So modafinil, we learned a lot about that with, again, in Complex Health 1 with obstructive sleep apnea. They are at risk for narcolepsy, excessive daytime sleepiness. So they kind of help stimulate respiration, all of that. And our methylxanthines are also kind of related to caffeine. So just keep that in mind as well. Depressants, on the other hand, have the opposite effect. Our barbiturates, they help a lot with seizures, epilepsy, sedation, benzodiazepines. These are more of our antipsychotics, anti-anxiolytics, and our anesthetics. This is anesthesia. So remember, general, this is whole body, usually used for putting someone under for a procedure. Regional, this is usually affecting larger areas of the body. Think of a C-section. Moms who are having a C-section, they are not asleep. They just can't really feel from the waist down, sometimes even the neck down. So that would be a regional anesthetic. And then local, this is a small part of the body. It has no severe CNS depression. So this is usually what's used if someone's getting stitches, etc. And just kind of keep that in mind. So now we're going to talk about our drug prototype for our barbiturates, phenobarbital. This is used for pre-op sedation. It's also used for seizures or status epilepticus, a seizure lasting longer than 5 minutes. And this is going to help potentiate GABA. However, what are the side effects of all barbiturates? Sedation. So just keep that in mind. These patients probably shouldn't be operating heavy machinery. They probably should be taking it easy, not driving, not exercising, not doing anything like that. However, these are not good for pregnant women. As you can see, pregnancy category D. With these drugs, you also have to monitor their therapeutic range because there's a very small window, okay? 15 to 40 is good. Again, always assess your vitals, and you do have to taper this medication. Dilantin, also known as phenytoin, this is really good for seizures. Again, a lot of drugs can be used for the same issue, but they're just working on a different thing, if that makes sense. Where if we go back to our barbiturates, these potentiate GABA and help influx chloride. Dilantin, this inhibits sodium reflux. So again, it's just working on a different thing, if you will, to kind of get to our goal. The one thing I do want you to know about a lot of our psychotic meds, they put the patient at increased risk for suicidal ideation. So also assess their mental health history is really, really important. Again, you'll kind of notice a trend. Lots of our psychiatric drugs are not safe for pregnancy. And again, very, very narrow therapeutic window. Diazepam, this one's actually used a lot for a lot of different causes. Is usually given IV push. a lot of these benzodiazepines end in Zolam or Zepam. We can give it for, again, status epilepticus if someone has very bad anxiety, if we're trying to sedate a patient, if a patient's going through alcohol withdrawals. Just really is an amazing drug at relaxing the brain. Okay, however, monitor their respiratory status because this drug can cause respiratory arrest. Also, lots of contraindications, so make sure we're getting a full health history on them. What drugs are you taking? What over-the-counter supplements are you taking? What CAM medications are you taking? And just kind of keep that in mind. If someone overdoses on a benzo, you can give them flumazenil. And always frequently assess your vitals. This drug specifically respiratory. Valproate is another drug that we can use for seizures, mania, migraines, and headaches. Again, it's reducing that neural firing frequency to calm the brain. This drug, though, I would know that it can prolong your bleeding time, so always monitor our platelets and clotting time. Really not safe for children under 2, and it is hepatotoxic. Again, lots of our psych meds also have very narrow therapeutic windows. So always monitor your therapeutic range. So I'm going to talk about medications for Alzheimer's and Parkinson's disease. So let's talk about the disease a little bit because it's going to help our pharmacology treatment make a little bit more sense. So with Alzheimer's, we have too little acetylcholine. So thus, we treat it by increasing acetylcholine. So what can we give them? Usually we give them acetylcholinesterase inhibitors because acetylcholinesterase, the function of that is to actually break down acetylcholine. So we have to stop the body from breaking down all of that acetylcholine, which is what's happening essentially in Alzheimer's. Again, there's really no cure for these, but treatment is kind of more focused on slowing the progression of symptoms and really improving their ADLs and improving their headspace, all of that. Parkinson's, too little dopamine, too much acetylcholine. So the drugs we give for Parkinson's will help restore those dopamine levels and block acetylcholine again, because we want a nice balance with Parkinson's. The issue with Parkinson's, the balance is off. So, acetylcholinesterase inhibitor. So, what did we just say are drugs of choice for Alzheimer's? Acetylcholinesterase inhibitors, because acetylcholinesterase attacks acetylcholine. So, we're going to stop the thing that attacks the acetylcholine, and that is what rivastigmine does. Lots of side effects. I would just know that bradycardia is really, really a concern with those patients because that's what we would call, an adverse effect, meaning this effect can cause harm to my patient, and we do not want that. For this drug, we always need to get baseline vitals. We also get a swallow study just to make sure it's safe for this patient to take this medication. Lots of our Alzheimer's patients have dysphagia, so just kind of keep that in mind. And we always monitor for an overdose. Remember we talked about bradycardia. That's kind of going to be pretty indicative of an overdose and some respiratory muscle weakness too. Benztropine, this is our anticholinergic. So remember with our Parkinson's, that's when we had too little dopamine, too much acetylcholine. So we're going to give them an anticholinergic, also known as a cholinergic antagonist. So this drug is really good for Parkinson's, but it also helps treat drug-induced Parkinsonism, which is indicative of like a lot of our psych meds have what's called extrapyramidal symptoms, which again will be more thoroughly discussed in the psych medication portion of your course, but it can also be used for that as well. Again, this drug, a lot of our side effects are our dries, dry mouth, urinary retention, dry skin. Why? That's just, remember, our anticholinergics are our dries. This is contraindicated in patients with glaucoma. So just keep that in mind. And again, because this can cause urinary retention, we have to do INOs on these patients. To help with the constipation, fluid, fiber, and fruits really do help. Relieving dry mouth can be achieved with ice chips, hard candy, etc. And these are our extrapyramidal symptoms, not specifically caused by Parkinson's disease, but a lot of drugs, side effects can be what we call these EPSs. So you'll kind of see these. So I just wanted to include this slide just so you guys can have it, because it will definitely help as you progress through this course. Dopaminergics, levodopa, carbidopa. Again, this is used for Parkinson's. Parkinson's, we have too little dopamine. So this drug mimics the action of dopamine to help restore that awesome balance. Specifically, why we give carbidopa levodopa is because it allows for more absorption past the blood-brain barrier. Okay. This drug, though, it can turn your urine and sweat brown, but that's completely fine. So educate your patient on that so they're not showing up to the ER and getting a really, really high hospital bill because they thought something was wrong because they had brown sweat. With these drugs, make sure these patients don't take vitamin B6 or alcohol because it can the B6 can affect absorption, and the alcohol is not good because this is harsh on the liver already. You have to be careful with this drug for an on-off effect, meaning usually these drugs aren't given every single day, but kind of in between doses, it can kind of wear off. So just keep that in mind. If it does wear off, there are other drugs we can give the patient to kind of help manage those symptoms during that on-off phase. Foods that are high in protein do interfere with the absorption of this medication as well. So if you were taking care of this patient and you were helping them place a breakfast order, you would maybe opt for some oatmeal and toast instead of eggs, bacon, and protein shake. So just keep that in mind. So now we're going to talk about more of our muscle relaxers. So myasthenia gravis, this is an autoimmune disease that destroys acetylcholine. This can thus impact their muscle contraction, causes muscle weakness. What happens? What's our main ABC concern? Respiratory. If I have respiratory weakness, I'm having ineffective breathing. Without treatment, myasthenia gravis can lead to a myasthenic crisis. This is severe muscle weakness, specifically of the diaphragm and intercostal muscles. So these patients will have a very difficult, hard time taking a deep breath in and a deep breath out. Okay. Lots of different causes, but usually for myasthenic crisis, there can be multiple different causes. But again, myasthenia gravis, it's an autoimmune disease, so we really just want to help suppress the immune system. So we usually give them prednisone, plasma exchange can help, immunosuppressive drugs, etc. So, neostigmine and pyridostigmine, both are acetylcholinesterase inhibitors. So these will help stop the breakdown of acetylcholine. Same drugs do the same thing. One just is short acting and thus has a quicker onset, and the other is intermediate acting, so it has a delayed onset, but it lasts in the body longer. And this really helps increase muscle strength in our patients with myasthenia gravis. However, this drug can cause some GI/GU symptoms, so just kind of keep that in mind. A drug that we usually give before administering this drug is atropine to help prevent bradycardia, because this drug, especially our short acting, has a very quick onset. It drops the heart rate very quick. An overdose can lead to a cholinergic crisis as well, so just keep that in mind. We're talking about multiple sclerosis, again, another autoimmune disease. This one is now attacking our myelin sheaths. What are we going to do? Treat with immunosuppressive therapy. We can give immunomodulators, immunosuppressants, antibody treatments, corticosteroids, etc. Interferon beta 1A is a very common immunomodulator. Again, it really helps these patients with MS. Most common side effect these patients have is flu-like symptoms. So just kind of keep that in mind. These drugs are also typically given via injection, so teach those patients proper administration. And what precautions would you need being on an immunomodulator? Your immune system is suppressed, so avoid large crowds. Um, don't eat raw fruits and veggies. Thoroughly wash your food, wash your hands, avoid sick kids, etc. Muscle relaxers, multiple different types of muscle relaxers, because again, with MS, we have that contraction and then that looseness. We have stiffness, rigidity, and then like no control and weakness. So we give them some muscle relaxants just to help with the spasms, okay? Cyclobenzaprine is a really good muscle relaxant, but this also does have some anticholinergic effects. What are anticholinergic effects? Again, those are our dries, so keep that in mind. Again, this drug shouldn't be given with alcohol or other CNS depressants because it does have that CNS depressant effect. Always monitor your liver enzyme levels, and again, this is a help. This also will depress our CNS, so our central nervous system. So they probably shouldn't be, again, driving cars, heavy machinery, but also it can alter their functional ability. So just keep that in mind. But this is not a long-term use med. So that's all I have for you guys. Now I have some practice questions for you guys. I also have the rationales, which I will discuss after we get some answers. So let's begin. A client with hypertension is prescribed clonidine. The nurse should instruct the patient to do we think A, B, C, or D? What are we thinking for this? What do we think we should do for clonidine? So the answer for this one is actually going to be C. We take this medication at bedtime. This is because this medication causes a lot of drowsiness. So we don't want them taking it during the day when they might be driving a car. This medication is not known to cause any sort of GI/GU issues. And taking it with food doesn't affect absorption at all. Again, dry mouth is common, so they wouldn't need to discontinue it. And you never ever double your dose or change your dose without consulting a healthcare provider. But this drug is dizziness is very common, so we have them actually take it at bedtime to avoid dizziness. I have another one. A nurse said they are taking ginseng supplements for fatigue. The nurse should instruct the patient to what do you think we should do? What do we think? Mm-hmm. Yep, good job. We stop taking the supplements and consult with the provider. Even if you don't know what ginseng is, you can kind of dissect these answers and kind of figure out where you're going. But ginseng is an herbal supplement, but we know that all of our supplements can have pretty bad interactions with prescribed medications or even harmful side effects. So they always have to consult the provider first. All right. A nurse is administering a medication to a client. Which of the following actions is considered a violation of the 6 rights of medication administration? Good job, guys. Awesome job. Yep. And I liked this question, even though it was fairly easy. A, B, C, and D are all things we should be doing. A nurse is caring for a newborn who is prescribed morphine, MS Contin, for pain management. The nurse should be aware of, or be aware that. Great job, guys. The nurse should be aware that the newborn's liver and kidney function may not be fully developed and will, in fact, impact their metabolism. Very, very good job. Because of this decreased function, they actually have an increased sensitivity. Not an increased sensitivity. But yeah, so just kind of keep that in mind. It should never be the same as the adult's dose. A client is prescribed prazosin, also known as Minipress, for hypertension. The nurse should monitor the client for which of the following side effects. So what should we monitor for a patient with Zosyn? And how would this impact our nursing care, really? Yep, dizziness. These patients are going to be a fall risk. Lots of our alpha 1 adrenergic antagonists have a common side effect of dizziness. This is due to that vasodilation property, thus can result in orthostatic hypotension. So these patients are really, really big fall risk. A client is prescribed a beta blocker for hypertension. The nurse should be aware that. Select all that apply. All right, so the answer for this is actually A and B. Okay. Our beta blockers, selected beta blockers don't necessarily have fewer side effects. It's just more that both selective and non-selective beta blockers do have similar side effects. It's not necessarily that one has more side effects than the other. One just shouldn't be used for patients that have a any sort of lung things. It's just a contraindication. A client is prescribed bethanachol for urinary retention. The nurse should monitor the client for which of the following side effects. All right. Good job, guys. Very good job. A client is suspected of overdosing on diazepam. The nurse should monitor the client for which of the following signs and symptoms. And then a bonus question, what is the antidote? So yes, diazepam is going to be B, drowsiness. Our antidote for diazepam is flumanazole. Great job, guys. So drowsiness, and our antidote is flumanazole. A client has been prescribed phenytoin for seizures. What education should the nurse provide to the client regarding this medication? And I know a lot of these medications you can, or sorry, a lot of these answers, excuse me, you can actually talk yourself through, like, oh, that seems right, that seems right, that seems right. But what's the most correct answer? What is a priority? Like, what do you think is most important out of some of these? What do we think for this one? Yep. I forgot to include this one's select all that apply, so that is my bad. I forgot to include the SATA. So this one is select all that apply, and the correct answers are C and D. The client should avoid alcohol due to this hepatotoxicity, the hepatotoxicity, and they should also not stop this medication suddenly in order to prevent seizures. Alrighty. A client with Alzheimer's disease have been prescribed rivastigmine. What's the primary mechanism of action of this medication? Rivastigmine. And even if you don't remember what rivastigmine does, you can narrow down your answer choices by understanding the patho of Alzheimer's. So if you're having a difficult time answering this question, that's okay. Think back. What's the issue with Alzheimer's? Because we treat based on the issue. Correct. It is A. It inhibits acetylcholinesterase. It stops the thing that breaks down acetylcholine. All right. A patient is prescribed to take carbidopa-levodopa, also known as Sinemet. As the nurse, you know that which statement is incorrect about this medication? What is incorrect about this drug? I see some A's, I see some C's. So the answer for this one is C. All of the other options are correct about this medication. However, the patient should avoid foods and supplements high in vitamin B6 because it decreases the effectiveness of this medication. A client with myasthenia gravis is experiencing a myasthenic crisis. What is the most appropriate intervention for the nurse to take? And I know this can be a little bit tricky. So the correct answer for this one is actually D, because we kind of have to understand a little bit of our routes of medication administration. So administering a corticosteroid is great for kind of long-term management of the disease, but it doesn't have a very quick onset. And a cholinergic agonist, it does have an effect, but it's pretty limited, and it's more like, again, for our use. If someone's experiencing a myasthenic crisis, they really do need plasmapheresis, because this removes all those harmful antibodies from the blood, which will improve muscle strength and weakness. Okay. So that is everything I have for you guys. If you haven't had the chance to sign in, go ahead and do so. But I appreciate you guys bearing with me for this review. And thank you so much for all of your participation.